I'm Dr. Sanjeev Nair, Professor of Pulmonary Medicine at Government Medical College, Thrissur in Kerala. I also am in charge of the TB task force for the South Zone 2, which includes Kerala, Tamil Nadu, Puducherry, and Attendance. So generally, TB is associated with poverty. Countries or regions which have more of poverty have generally more of TB. Doesn't mean that only poor people have TB. In fact, TB is an infectious disease, can affect anybody, irrespective of whether they are rich or poor. So even rich people can develop TB. But generally, it is the poorer people who suffer more due to TB. They have more of TB because generally, they live or work in situations which are overcrowded, where you have poor ventilation, which leads to more spread of TB. In addition to this, poorer people generally have less access to proper nutrition. They're generally malnourished. They have other diseases also which reduce the immunity. And addictions like smoking or alcohol, which are common, also will reduce the immunity, which causes more of TB. So generally, there will be more TB occurring in populations which are poorer. The other side of the story is also true. So when you have people who are having TB, they're not able to go to work. Their household income comes down, and because of that, patients do become poorer. Patients and families become poorer. So TB can increase the poverty in families, and poverty can increase the incidence of TB in families. So I think it goes that way. And from countryside also, huge country and regions, if you have more of TB, you have more of cost to the country in terms of productivity and income, and does affect the economy of countries as well. So stigma is very common in all chronic diseases, particularly diseases like TB, leprosy, and all that. So generally, when a patient has the disease, tuberculosis, population, the community, even the families often discriminate against these patients. So they try to keep a distance from the patient. They don't give the patient the normal privileges that the patient would have in a family. For example, some families make them, have food and all from separate plates and glasses, which is not needed because TB is an airborne disease. Whether you keep up a separate plate or glass will not make any difference in the spread of TB. It's not a disease which is spread through food. So, you bring in practices which actually isolate the patient and make the patient feel isolated. People do get stigma at workplaces. So if you reveal in your workplace that you have TB, many people have seen people losing their jobs. So they have to keep quiet about their TB. They don't mention about TB outside. It has consequences on patients as well. So, if you're frightened that people will know about your TB and differentiate against you, you will try not to get diagnosed. You will not go for diagnosis. So there will be delayed diagnosis of such people. And even when they have diagnosis, they will not go for proper care because they want to hide their disease. And that will lead to the disease becoming more severe and even people dying due to TB. So I think stigma really affects TB, and that is something that we all fight against stigma and TB. There's no need to stigmatize. I mean, you can hold your TB patient, you can hug them. Only thing is you have to take care of airborne infection control. That is, the person who has tuberculosis should wear a mask and should take care to dispose the sputum properly. Other than that, there is nothing to differentiate with the TB patient. I think if we take our country, we have more incidence of TB in the crowded areas in terms of, infection in urban areas, in slums and all that. But often you see that there is more of TB prevalence in the rural areas. This is because people do not have proper access to care. So for the diagnosis of TB, you need two major tests. One is the sputum examination. Sputum examination traditionally is done by a smear microscopy, which often is available in every institution, even in the periphery. So that is not a problem in the government system. But the other test required is a chest X-ray. So a chest X-ray is often not available in the rural areas, in the peripheral areas. And if at all X-ray is taken, generally there will not be a provider there, a doctor there, or somebody who can read these X-rays properly and make a diagnosis. So about 50% of cases would be diagnosed on X-ray. And nowadays there are newer technologies like Gene Expert and other machines which are technology based. So the advent of these new machines, which are molecular tests, particularly the Gene Expert machine and the TrueNat machine, have revolutionized the way we diagnose TB. So the TB diagnosis has gone a long way. from the days when we were dependent simply on smear microscopy. So in a way, technology has revolutionized the way we diagnose TB. However, these machines are often available only in the taluka level or district level hospitals. But the TB program of India has built, transport mechanisms so that sputum can be collected from the remote areas of the country and be taken to the centers for testing. The other side is, chest X-ray, which is also needed for the diagnosis of TB. Our national TB prevalence study has shown that a significant percentage of our TB patients will not be diagnosed unless an X-ray is taken. So the problem is getting X-rays taken in the periphery and also getting the X-rays read in the peripheral centers. So here again, technology has helped us in a big way. Nowadays, you have handheld X-ray machines, which can go to any nook or corner of the country, even the hilly areas, the remote areas. You just need one person who has probably a two-wheeler or some way of transportation. They can even carry the X-ray machine on a backpack or in a bag, and they go and take the X-ray in the community of the person. And these X-rays can be transmitted by internet, by telemedicine to centers where there is artificial intelligence, which actually reads these X-rays. And the artificial intelligence tools are quite good now, and they can actually pick up lesions which may not even be picked by doctors who are not too experienced with the diagnosis of TB. So these technologies have helped us a long way in the diagnosis of TB. Technology has also helped us in the treatment of TB in terms of increasing patient compliance with treatment. So you have various ways of monitoring whether the patient is taking treatment properly. In TB, a major issue is that people often forget to take their drugs, or they don't complete the full course of drugs. So you have reminders which come on the boxes, or you have telephone calls which can be made in systems called 99 dots. So you have various systems which actually technology-driven systems which help the patient to remember to take the medicines and all. In fact, technology is going even further, and nowadays, we are looking at cough sounds which can actually help us to screen and find out the people at the highest likelihood of TB. So many new technologies are coming. You have drones being used in remote parts of the Himalayan region and all to ensure that medicines reach people in very remote areas. So a lot of work is going into technology in TB, and it will definitely help us to improve our diagnosis of TB. In fact, today we can do whole genome sequencing of the entire TB bacterial genome, and in fact look at various smaller mutations, and even that is available all over the country. So a lot of emphasis on technology in TB, and definitely it's helping our TB patients and the people providing treatment to TB, treatment diagnosis of TB patients, to improve the care we can give to our people. I think starting from our own country, our TB program has been a major success. We have one of the biggest TB programs in the world. We have, of course, the largest number of TB patients, but our TB program also gets access to almost 85% of the estimated incidence by WHO, and we are providing good quality care. The treatment outcomes are quite good today in the country, even for drug-resistant TB. So, earlier we were worried about patients with drug-resistant TB or HIV TB, but today, in our country at least, the treatment outcomes are dramatically improving for even drug-resistant TB, and we are doing fairly well. Having said that, there are still better or other models in various other countries in the world which actually help to take care of patients better. Of course, in our country, large numbers of patients are there, so that is a major challenge for us. But many other countries are able to give individualized care to TB patients. Many countries can still, admit or give patients individualized care, or some countries like Nepal and all have hostels where they admit their, they take care of the MDR TB patients, so that they get better care. Other than that, many of the countries are now moving forward with a newer regimen, so newer treatments for TB. Until recently, we believed that for drug-sensitive TB, that is TB bacteria with no resistance, minimum of 6 months of treatment is required. But now WHO and other agencies have, American CDC and all, have endorsed treatment of 4 months for drug-sensitive TB, and these have come into the guidelines in the US. So these regimes, even shorter treatment of even 4 months of treatment is good enough for drug-sensitive TB. And for drug-resistant TB, WHO and other countries have endorsed treatment for 6 months. The BPAL and the BPAL-M regime are very promising, which can be given for 6 months. So these treatment regimes are also available in many of the African countries and many other parts of the world. So I think we are moving towards faster and better diagnosis, particularly using molecular technology, and also looking at shorter and shorter regimes for TB. At one time, my patients with drug-resistant TB used to get like 2 to 3 years of treatment. Now, in our country itself, the treatment is the shorter regime is like 9 to 11 months, but that can even become shorter in the future. And there are many other countries who are doing this, and such models are available. I would like to tell all TB patients that their disease is easily diagnosed and fully treatable if they take a full course of treatment. The diagnosis of TB as well as the treatment of TB in our country is absolutely free. For example, the diagnostic algorithm of TB, when you have to do a set of tests, all these tests put together could cost somewhere around 20,000-30,000 rupees, and the whole thing is given free of cost in our country if you access those services. And for treatment also, general drug-sensitive TB, the treatment may not be too costly, but still it is costly. But when it comes to drug-resistant TB, we are giving extremely costly drugs, which runs into lakhs of rupees, and the entire course of treatment is given free of cost to patients. So, anybody with cough more than 2 weeks, fever more than 2 weeks, unexplained loss of weight and loss of appetite or splitting out of blood, please go to the nearest diagnostic center of the NTEP. These centers are available all over the country. Get your sputum tested, get the X-ray taken, which is done free for you. And once if you're diagnosed as TB, please take the full course of treatment. The drugs are available free, but you have to take the full course of treatment without any failure, so that you don't develop drug resistance and you get full cure from your TB disease, which is definitely possible.